Hello and welcome. I'm Professor Shaibu Oricha Bello, and in this lecture we're going to explore Anthelmintics, the drugs we use to treat infections caused by parasitic worms. Whether you're a medical or a pharmacy student, this is a high-yield topic that shows up in your exams and, far more importantly, in everyday clinical practice across much of the world. Over the next several slides, I'll walk you through the major drug classes, how each one works, what we use them for, and the growing challenge of resistance. So grab a pen and a notebook and let's get started. Before we dive in, let me give you a quick map of where we're heading. We'll start with the global burden of worm infections, why this really matters. And then we'll meet the parasites themselves, the nematodes, the cestodes, and the trematodes. From there we move into the drug classes, from the benzimidazoles all the way to praziquantel. And I'll explain the mechanisms behind how each one kills or expels the worm. Then we'll get practical, looking at the drug of choice for each infection and their cure rates, before finishing with resistance and the mass drug administration programs that are reshaping global health. Keep this roadmap in the back of your mind. It'll help everything fall into place. Let's start with why this topic matters so much. Helminth infections are among the most common infections on Earth. More than 1.5 billion people carry soil-transmitted helminths, and over 650 million are at risk of lymphatic filariasis across 39 countries. And these are not trivial infections. They drive chronic anemia, malnutrition, and growth stunting, especially in children. The encouraging news is that since the year 2000, more than 9.7 billion preventive treatments have been delivered, and the World Health Organization targets 7 priority neglected tropical diseases for mass treatment. So as you learn these drugs, remember they're tools in one of the largest public health efforts in human history. To choose the right drug, you first have to know your enemy. Helminths fall into 3 groups. First, the nematodes or roundworms. These include ascaris, hookworm, whipworm, pinworm, strongyloids, and the filaria. Second, the cestodes or tapeworms, which are flatworms. Think of the tinier species from beef and pork, the fish and dwarf tapeworms, and echinococcus, which causes hydatid disease. And third, the trematodes or flukes, also flatworms, including the blood flukes like schistosoma, plus the liver, lung, and intestinal flukes. Hold on to this classification because, as you'll see, our drug choice maps directly onto whether we're facing a roundworm or a flatworm. Here's the big picture of our drug toolkit. The benzimidazoles, albendazole, mebendazole, triclabendazole are our broad-spectrum antimalarial backbone. The macrocyclic lactone ivermectin handles the filaria, strongyloids, and river blindness. The nicotinic agonist pyrentol, lavamisole, and piperazine target luminal nematodes. Praziquantel is our go-to for the flatworms, both flukes and tapeworms. Niclosamide is a narrow agent just for intestinal tapeworms, and diethylcarbamazine, or DEC, is our antifilarial. Now, don't try to memorize all of this at once. I'll take each of these one at a time in the slides that follow. So how do these drugs actually work? The key principle is selective toxicity, hitting something vital to the worm but sparing us the host. And broadly, there are two strategies. The first is to starve the worm by disrupting its energy metabolism. Benzimidazoles bind beta-tubulin and block microtubule assembly, and niclosamide uncouples oxidative phosphorylation, so the parasite simply runs out of energy. The second strategy is to paralyze the worm by disrupting its neuromuscular control. Pyrantel and levamisole cause spastic paralysis. Piperazine causes flaccid paralysis. Ivermectin opens chloride channels, and praziquantel triggers a calcium-driven tetanic paralysis. Starve or paralyze. Every single drug we discuss today fits into one of those two buckets. Let's begin with the benzimidazoles: albendazole, mebendazole, and triclabendazole. Mechanistically, they bind the worm's beta-tubulin, preventing microtubule formation and blocking glucose uptake, so the parasite literally starves. Clinically, these are workhorses. A single 400 milligram dose of albendazole treats ascaris, hookworm, whipworm, and pinworm, and with longer courses we use it for hydatid disease and neurocysticercosis alongside steroids. Here's a pharmacokinetic pearl I want you to remember. Their oral absorption is poor and variable, but a fatty meal boosts it. Handy when you need to reach a tissue infection. They're generally well tolerated, but keep an eye out for raised liver enzymes, rare marrow suppression with prolonged use, and remember they're teratogenic, so we avoid them in the first trimester. Next up is ivermectin, a macrocyclic lactone derived from a soil bacterium, Streptomyces avermitilis. It works by opening glutamate-gated chloride channels in the worm's nerve and muscle, causing hyperpolarization and flaccid paralysis. This is our drug of choice for strongyloidiasis and for onchocerciasis, river blindness, and it's a mainstay of filariasis control programs, as well as scabies and lice. Now here's a beautiful piece of pharmacology. Ivermectin doesn't readily cross our blood-brain barrier because P glycoprotein pumps it back out, which is exactly why it's safe for us but lethal to the parasite. Two cautions, though: be careful in patients with heavy low loads because of encephalopathy risk, and avoid it in children under 15 kilograms. Now to the nicotinic agonists, and this is an exam favorite because of a lovely contrast I want you to lock in. Pyrantel and levamisole are nicotinic agonists. They cause spastic or tetanic paralysis. Piperazine, on the other hand, is a GAB agonist. It causes flaccid paralysis and the worm is expelled alive. Because those two mechanisms oppose each other, you must never combine pyrantel with piperazine. Pyrantel promote is poorly absorbed, and that's actually perfect. It stays in the gut lumen to act on pinworm, roundworm, and hookworm, and it's safe in children. Side effects are mild, a little GI upset and dizziness. But do be careful with piperazine in renal impairment, where it can become neurotoxic. Diethylcarbamazine, or DEC, is our dedicated antifilario. It's a piperazine derivative that immobilizes microfilariae, alters their surface membrane, and enhances the host's own immune clearance. We use it for lymphatic filariasis caused by Wuchereria and Brugia, for loiasis, and for tropical pulmonary eosinophilia, and it's a core drug in mass drug administration, except in areas where onchocerciasis is endemic. And that's the critical safety point I need you to remember. DEC is contraindicated in onchocerciasis because the sudden death of microfilaria triggers a severe Masotti reaction affecting the eyes and skin. Be cautious too where low burdens are high. It's well absorbed orally and cleared by the kidneys. Praziquantel is one of the most important drugs in this entire lecture. It's our drug of choice for the flatworms. It increases calcium permeability across the worm's tegument, causing a tetanic contraction and vacuolization of that protective outer layer, which exposes the parasite to the host's immune system. We use it for all species of schistosomes, the blood flukes, as well as liver, lung, and intestinal flukes, adult tapeworms, and neurocysticercosis, sometimes combined with albendazole. It's rapidly absorbed but heavily metabolized on first pass, so it has a short half-life, and we take it with food. Side effects are common but transient: abdominal pain, nausea, dizziness, and take special care in ocular cysticercosis. Niclosamide is a narrow-spectrum agent, and its job is tapeworms in the gut. It inhibits oxidative phosphorylation in the worm's mitochondria and blocks glucose uptake, killing the scolex, the head, on contact. We use it for beef, pork, fish, and dwarf tapeworms, and it's an alternative to praziquantel for intestinal cestodes. Note that it has no activity against roundworms or flukes. Because it's minimally absorbed, it acts right there in the gut lumen, and the killed worm is passed in the stool. It's well tolerated, but there's an important caveat with the pork tapeworm. Taniosolium released ovaries a theoretical concern for cysticercosis, and do note it's been discontinued in some markets, including the United States. Let's bring it all together clinically. For ascariasis, we reach for albendazole or mebendazole. For hookworm, albendazole, which has a much higher cure rate than pyrantel. For whipworm, we combine albendazole with ivermectin. Pinworm responds to albendazole or pyrantel. And do remember to treat the whole household and repeat the dose in 2 weeks. Strongyloids is ivermectin's territory. Lymphatic filariasis uses DEC, often with albendazole or ivermectin, depending on what's co-endemic. Schistosomiasis and the flukes call for praziquantel, with triclabendazole reserved for fasciola. And tapeworms respond to praziquantel or niclosamide, while tissue cysts need albendazole. Honestly, if you memorize just one slide for your exam, make it this one. Now I want you to appreciate that efficacy is not uniform. It depends on the specific drug and parasite pairing. Look at this chart with me. Ivermectin achieves essentially 100% cure in Ascaris, and albendazole around 88%. But for hookworm, albendazole 72% towers over pyrantel's 32%. Pinworm is easy, about 94% with albendazole. And for strongyloids, ivermectin's 95% clearly beats albendazole's 63%. So the takeaway is twofold: match the drug to the species, and notice that where a single drug performs poorly, as it does with whipworm, that's precisely why we turn to combination therapy. Safety deserves its own moment. As a class, every anthelmintic can cause gastrointestinal effects: nausea, cramps, diarrhea, and reactions from dying parasites such as fever, itching, and urticaria. In terms of organ toxicity, remember benzimidazoles can raise liver enzymes and rarely suppress the marrow, and piperazine is neurotoxic in renal impairment. In pregnancy, avoid albendazole and mebendazole in the first trimester, and prefer parenteral if treatment is truly essential. And keep those key cautions front of mind. Avoid DEC and ivermectin with high low burdens. DEC is contraindicated in onchocerciasis, and ivermectin isn't for children under 15 kilograms. Good prescribing is as much about these cautions as it is about the mechanisms. Now for a growing threat: anthelmintic resistance. Here's the core problem: we have very few chemically distinct classes, so resistance to one compound often confers side resistance across the whole class. There are three main mechanisms. First, target site mutation through amino acid substitutions in beta-tubulin blunt benzimidazole binding. Second, drug efflux. Increased P glycoprotein pumps the drug out before it can act. And third, loss of the target. Reduced expression of receptors or ion channels simply removes the drug's docking site. The answer is stewardship: rotating drug classes, using combinations, dosing correctly, and monitoring cure rates. We learned these lessons the hard way in veterinary medicine, and our human programs must not repeat them. Let's zoom out to public health. For endemic communities, the World Health Organization recommends periodic preventive chemotherapy, essentially treating whole populations to push infection below the threshold for transmission. Think of it as a 4-step cycle. First, we map the endemic districts. Second, we treat with annual mass drug administration using safe drug combinations. Third, we monitor using the Transmission Assessment Survey. And fourth, we sustain with post-treatment surveillance to catch any resurgence early. The impact has been extraordinary. Since the year 2000, over 9.7 billion treatments have cut lymphatic filariasis prevalence by 74%, and more than 870 million people no longer require preventive chemotherapy. This is medicine operating at a truly global scale. Before we wrap up, let me hand you some memory hooks to lock all of this in. For the benzimidazoles, think 3Bs, they bind beta-tubulin. For praziquantel, remember it targets platyhelminths, the flatworms, both flukes and tapeworms. For ivermectin, the MECT sitting in the middle of the name reminds you it opens chloride channels, and it treats river blindness, strongyloids, and scabies. Contrast parental's spastic paralysis with peperazine's flaxseed. And never combine the two. DEC helps you detect and clear the filaria, but avoid it in onchocerciasis. And nicotinamide gives no cyst cover, so mind the Taenia sodium risk. Say these out loud a few times. They will serve you very well on exam day. Let's finish with 5 things. I really want you to carry away. 1. Match the drug to the parasite. Benzimidazoles for intestinal nematodes, ivermectin for strongyloids, and filaria praziquantel for flukes and tapeworms. 2. Every drug either starves the worm or paralyzes it. 3. Pharmacokinetics guide use. Poorly absorbed agents hit the luminal worms, while absorbed agents reach tissue disease. Fall mind the special cases. Avoid benzimidazoles in early pregnancy and never give DEC in onchocerciasis. And 5. Respect resistance. Practice good stewardship because mass drug administration underpins global elimination efforts. Thank you so much for watching. If you found this helpful, do share it with a classmate, and I'll see you in the next lecture.